Welcome. Thanks for joining us for our third in a series of reviews of preterm nutrition, evidence and practice, feeding strategies and methods. I'm Roger SOLL, and on behalf of our editorial team, including Bill McGuire, my co-coordinating editor, Michelle Fiander, our information specialist, and stepping up as one of our managing editors, and Charlotte Crowley, our program coordinator. I'd like to take the opportunity to introduce you to one of our new part-time managing editors, Pua, who joins us from the Cochrane Fertility and Regulation Group. We're really looking forward to this expansion of our team and adding her expertise to the Cochrane neonatal crew. I'd also like to welcome you on behalf of our senior editorial team, Jeff Horbar, Prakesh Shah, Suresh Gotham, Jackie Ho, and David Osborne, as well as our ever-broadening group of associate editors who provide guidance and feedback on all of our reviews. For today's discussion, we are privileged to have two of our editorial team joining us as guest discussants, Bill McGuire and Suresh Gotham, as well as Brenda Poindexter joining us from Emory University School of Medicine. Our sponsors for these seminars are, of course, Vermont Oxford Network and sponsoring Cochrane at Vaughan, as well as some specific funds received from the Gerber Foundation for an unrestricted grant to support updated reviews on feeding preterm infants. As a matter of disclosure, I am Vice President of Vermont Oxford Network and coordinating editor of Cochrane Neonatal, but have no other relevant financial issues to disclose. The purpose of this series of seminars has been to develop an understanding of the strengths and weaknesses of evidence provided by systematic reviews and meta-analyses to inform our practice of neonatal perinatal medicine. The focus of today's seminar will be on how we can optimize feeding strategies and methods in preterm infants. So let's set the stage for why these seminars are important. I think we can generally agree that most neonatologists have embraced the recommendations of the American Academy of Pediatrics and feel that the growth of postnatal preterm infants, both in their anthropometric indices and body composition, should try to mimic the normal fetus at the same gestational age growing in its mother's uterus. This is an interesting teleological concept, and there is some debate over it. But in reality, we do use this as one of our concrete aims. But the fact of the matter is, this proves to be a challenge. Reports from NICUs across the world demonstrate that we have considerable room for improvement. The growth of nearly all preterm infants during their hospitalization in intensive care, especially those who are the most preterm, lag far behind the fetal growth curves in the third trimester. Work that's been done here at Vermont Oxford shows us that 31% of very low birth weight infants have what we defined as extreme growth failure, being less than the third percentile on the Fenton growth charts. This failure in sustaining adequate growth varies greatly between centers, with the first quartile having 20% or fewer infants with extreme growth failure, but the third quartile having 40% or greater infants with extreme growth failure. Clearly a problem for many of our units. When we look at practice, we see that there's a great deal of variation in feeding practices. Just one example from this survey in 2012 is taking a look at when we initiate feeds, one of the subjects of today's seminar. So for example, for babies 25 to 27 weeks, all of the centers in Scandinavia report that they routinely initiate feeds in the first 24 hours of life, whereas only 15% of units in Australia report routine use this early on. We'll examine some of those practices today, as well as many others, regarding how we feed our babies. What are the downstream effects of undernutrition and growth failure? Numerous studies have shown that failure to meet the preterm infant's nutritional goals at critical stages of development produce serious problems for the preterm infant. Some of them are very concrete in terms of growth, short stature, and growth failure. But importantly, many of them involve more subtle and perhaps more important outcomes, such as abnormalities in brain growth and infant development. So let's examine the gaps in caregiver knowledge and practice regarding early enteral nutrition for preterm infants. We've identified three key areas of gaps. In our first seminar, we discussed the types of feedings, the substrate. In the second, we looked at how we can optimize nutritional content. And in this last seminar, we'll take a look at feeding strategies and methods. So, what do we actually know from trials of feeding strategies and methods? Well, Cochrane has a long list of reviews that are somewhat eclectic, and I'll try to review them now in the time we have. I'll deal with the facts from the reviews, and then we'll be joined by guest discussants who will take a look at the evidence and discuss how it fits into our practice and what are the other areas where research should occur. I've grouped the reviews into these four areas. And again, they're somewhat eclectic, but I hope you see how they're related and how they support each other. The first area is how we introduce enteral feeds, at what time and how we advance. The second is methods for promoting successful enteral feeds. The third is specifically the methods we use for enteral feeding. And then as we go on with our feeding, what are the strategies that support the success of enteral feeds? So let's discuss the introduction of enteral feeds. There are four reviews in Cochrane that address issues about how and when we introduce enteral feeds. There's a review of early trophic feeding versus enteral fasting for very preterm or very low birth weight infants. This review from Morgan and colleagues includes 9 trials and a total of 754 infants. There's the review of Young and colleagues of delayed introduction of progressive enteral feeds to prevent necrotizing enterocolitis in very low birth weight infants. This trial has even more reviews, 14 trials, for a total of 1,551 infants. Somewhat fewer trials address the issue of early full enteral feedings for preterm or low birth weight infants. Walsh and colleagues report on 6 trials involving 526 infants. And Odie and colleagues take a look at the rate of advancement, of slow advancement of enteral feed volumes to prevent necrotizing enterocolitis in very low birth weight infants. This review includes 14 trials involving over 4,000 infants. These studies all have a somewhat similar rationale for why the introduction of feeds may matter. Often, we delay in introducing enteral feeds due to concern that early introduction may not be tolerated and may increase the risk of necrotizing enterocolitis. Observational studies suggest that more conservative feeding regimens, including the slow advance of enteral feeds, may reduce the risk of necrotizing enterocolitis. However, it is unclear whether prolonged enteral fasting may diminish the functional adaptation of the immature gastrointestinal tract and ultimately delay establishment of full enteral feedings. Slower feed advancement may also be associated with infectious morbidities secondary to prolonged exposure to parenteral nutrition and the need for central intravenous access. Trophic feeds represent a somewhat unique aspect of feeding introduction, in which infants are given very small volumes of milk to promote intestinal maturation, enhance feeding tolerance, and decrease the time taken to reach full enteral feedings independently and reduce the risk of NEC. Now, these interventions and these titles all sound a little bit the same, and they are related, but I'd like to specifically define what is meant in each of these interventions. Ultimately, they're all interventions about when we start, how fast we start. But they take slightly different views, and the fact of the matter is that you have to choose between them because they are not identical. Let's first define early trophic feeds. Early trophic feeds, feeding of milk volumes up to around 24 ml per kilo per day, introduced before 96 hours of postnatal age and continued for at least 1 week of birth, represent a type of priming feeds compared to a comparable period of enteral fasting. Delayed feeds don't focus only on minimal trophic feeds, but basically they wait at least 4 days after birth compared to earlier introduction of progressive enteral feeds. Early full enteral feeding of 60 ml per kilo to 80 ml per kilo on day 1 after birth versus minimal enteral feedings, typically defined as 20 ml per k on day 1 and supplemented with intravenous fluids, and then followed by advances tolerated about 20 to 30 cc's per kilo of body weight to achieve a target steady state volume of any place from 150 ml per kilo to 180 ml per kilo. And lastly, slow advancement of enteral feeds, trials typically defined as daily increments of 15 to 24 ml per kilo, or faster advancements in increments of 30 to 40 ml per kilo. So what's the clinical impact of these different but related strategies to feeding? Well, of course, in the back of our minds, the single biggest issue is making sure that infants don't go on to develop necrotizing enterocolitis. And in fact, all 4 of these reviews report on NEC. Early trophic feeds include 9 studies of 748 infants. The delayed introduction of progressive enteral feeds includes 13 studies of 1,507 infants. Early full enteral feedings has 6 studies of 522 infants. And lastly, slow advancement has 14 studies with over 4,000 infants. When we look at the relative risk and confidence interval from all of these studies, we see that there is no evidence of effect on necrotizing enterocolitis. The relative risks all harbor around 1, and the confidence intervals are consistent either with a decrease or increase in risk. One could argue that for many of these approaches, there is a lack of precision around these estimates, suggesting that they could be, such as, for example, early full enteral feeds, either very beneficial or very harmful, and that we don't have anything close to a precise answer regarding this important outcome. Similarly, these 3 approaches do not show any evidence of effect on mortality. For these studies, again, the relative risk here for early trophic feeds, the point estimate is 0.66 with a confidence interval of 0.41 to 1.07. The others are similarly harboring in and around 1, but with a confidence interval that can include both benefits and harms. The reviews that have fewer studies and fewer infants have less precision and allow us no real insight into whether or not these approaches decrease mortality. Interestingly, we do see some effects on sepsis, on the risk of invasive infection. For early trophic feeds, there are only 3 studies involving 237 infants that report on on invasive infection. And the relative risk is 1.06 with a confidence interval of 0.72 to 1.56. For delayed introduction of progressive feeds, there are 7 studies involving 872 infants. Now, in this case, the intervention is delayed introduction. So the increased risk that's reflected here represents that there is a relative risk of 1.44 with a confidence interval that suggests that it's 1.15 to 1.80. This tells us that there's an increased risk of invasive infection associated with delaying the introduction of progressive enteral feeds. No effect is seen on infection with early full feedings, and there is a trend towards increased infection with slow advancement of feeds. Why might that be? Well, one can speculate that this is in part due to the fact that in infants who either have delayed introduction of enteral feeds or slower advancement, that they are exposed to longer periods of time on parenteral nutrition and may have invasive access in order to deliver that nutrition, putting them at risk for infection. Length of hospital stay is in order to deliver that nutrition, putting them at risk for infection. Length of hospital stay is reduced with these more aggressive feeding practices. So for early trophic feeds, there is an approximately 4-day reduction in hospital stay. Delaying introduction of progressive feeds adds about 4 to 5 days to hospital stay. Early full enteral feeding decreases hospital stay by about 3 days. And we know little about slow advancement of enteral feeds, as they were measured differently in the studies, 2 studies showing no difference, and 2 studies reporting a longer duration of hospital stay in infants with the slow advancement. This mimics our findings about infection, that infants who stay longer based on slower introduction of enteral feeds. One can debate the meaningfulness of 3 or 4 days of increased or decreased hospital stay, but this is a short-term benefit that is associated with more aggressive feeds. There are many secondary outcomes that are reported in these studies. For the early trophic feed studies, there are no evidence of effects about when these infants reach their full enteral feeds, when they regain birth weight, or their length of hospital stay. For delayed introduction of progressive enteral feeds, we see an increased length of hospital stay, but no reported effects on growth. For early full enteral feeding, we see decreased days to regain birth weight and length of hospital stay, but uncertain effects on feeding intolerance or longer-term growth. Slow advancement of enteral feeds, so delayed establishment of enteral nutrition, adds about 1 to 5 days longer time to regain birth weight and uncertain effects on feeding intolerance. And so what we see overall when it comes to these trials of introduction of enteral feeds is no major clinical outcomes such as NEC or death being affected, but some perhaps important benefits regarding infection, length of time to regain birth weight, and length of hospital stay. So let's take a look and shift gears a little bit to other aspects of feeding strategies, in this case, how we promote enteral feedings. This is an eclectic group of reviews that I've grouped here. It includes Allen and colleagues' review of avoidance of bottles during the establishment of breast feeds, which includes 7 trials and 1,152 preterm infants. Foster and colleagues' study of non-nutritive sucking for preterm infants involving a great number of trials, 21 trials, but only 1,186 infants, so lots of small trials, but with an aggregate of a fair number of infants. And oral stimulation for promoting oral feeds. Again, a large number of trials, 28 trials, and a fair number of infants, but you can see by doing the simple math that there are many smaller trials included in this review. The rationale for each of these is all a little bit different. For the avoidance of bottles during the establishment of feeds, we know that many preterm infants start their milk feeds via gavage tube. As they mature, sucking feeds are gradually introduced. Women with preterm infants may not always be in hospital to breastfeed their babies and need an alternative approach to feeding. Most commonly, milk, hopefully as expressed breast milk, but sometimes as formula, is given by bottle. Whether using bottles during the establishment of breastfeeds is detrimental to breastfeeding success is a topic of ongoing debate and the focus of these trials. Non-nutritive sucking for increased physiologic stability and nutrition is another approach to optimizing the feeds. Sucking on a pacifier, non-nutritive sucking, during gavage feeds may encourage the development of sucking behavior and improve digestion of the feeds. Oral stimulation has also been used to promote oral feeding in preterm infants. And there are a range of oral stimulation interventions that may help infants to develop sucking and oromotor coordination, which will help promote earlier feeding and earlier hospital discharge. So, what exactly is the intervention? They're all a little bit different. Avoidance of bottles during the establishment of breastfeeds in preterm infants has several strategies that have been used. Most of the trials that are included looked at cup feeding strategies, but one trial looked at tube feeding strategies, and one trial looked at a novel nipple teat for supplements of breastfeeds when needed. Non-nutritive sucking is what it says it is. It's sucking on a pacifier during gavage feeds. The reviews of oral stimulation for promoting oral feeds have either compared oral stimulation interventions to standard care or to other types of stimulation, like body stroking or gavage adjustments. So, what are some of the effects of these approaches to enhancing and promoting breastfeeding and nutrition? There are 6 studies looking at the effect on full breastfeeding at discharge that studied the use of avoidance of bottles. There are over 1,000 infants enrolled in these studies, and they demonstrate an improvement in full breastfeeding at discharge associated with avoidance of bottles. For non-nutritive sucking, there's really only one study of 303 infants, which does not show a difference of breastfeeding at discharge. And the studies of oral stimulation suggest that full breastfeeding at discharge will be increased in the infants that receive oral stimulation. Let's take a closer look at the review of avoidance of bottles during the establishment of breastfeeds. And here are the results from this one review of avoidance of bottles, looking at both full breastfeeding and any breastfeeding, and looking not just at discharge, which is what I reported previously and is clearly improved with avoidance of bottles, but whether or not these gains, in fact, are continued 3 months and 6 months post-discharge. And importantly, I think we see that they are, that there is better acceptance and sustained use of breastfeeding, even within the 6 months after hospital discharge. There were no harms associated with avoidance of bottles, including one thing you might be concerned about is increasing length of stay. The effect on weight gain is really less well reported in these studies. In the avoidance of bottles studies, it is variably reported and there is no proven effect. The 5 studies of non-nutritive sucking involving 221 infants do show a somewhat higher mean weight gain expressed in grams per day, but it is relatively small. The point estimate is 4 grams per day higher. It may be anything from 3 to 5 grams per day higher. And the reviews of oral stimulation do not report on this aspect of growth. Hospital stay is in fact changed with some of these strategies. For the avoidance of bottles, the mean hospital stay was 2.3 days higher, but the confidence interval suggests that it could be slightly lower, around 3 to 4 days lower, or up to 8 days higher. The 12 studies of non-nutritive sucking involving 825 infants did show a decrease in the length of hospital stay, with the point estimate being approximately 7 days, and it could be as many as 8 days lower or as few as 6 days lower. But here we have what I think many would see as an important short-term gain of almost a week less hospital stay in infants who were given non-nutritive sucking. The studies of oral stimulation, whether they compared them to standard care or to other non-oral interventions, also showed a decrease in length of stay, the decrease being, and the point estimate maybe 4 days lower or 6 days lower. Again, short differences, but certainly meaningful to families. When it comes to other longer-term clinical outcomes, there's not a lot we know from these approaches. Necrotizing enterocolitis is not reported in any of these studies, either the avoidance of bottles studies, the non-nutritive sucking studies, or the studies of oral stimulation. So we really don't know if any of these improves gut function and decreases these diseases. So then, moving through this, we come to some of the methods of enteral feeds. And for this aspect of the review, we have 3 studies, 3 systematic reviews to look at. We have Watson and colleagues' review of transpyloric versus gastric tube feeding involving 9 trials and 359 infants. We've got Sadruddin's study of continuous nasogastric milk feedings versus intermittent bolus milk feedings in preterm infants, with 9 trials involving 919 infants. And we have push versus gravity for intermittent bolus gavage feeding, involving 1 small crossover trial. So there's very little evidence for that intervention. The rationale for these are all slightly different. For transpyloric versus gastric tube feeding, it's very clear that for most extremely preterm infants, enteral feeding is commenced via tube, a nasogastric or orogastric tube. Transpyloric tubes, where the tube passes beyond the pylorus into the upper small intestine, is an alternative means to delivering enteral milk and has been suggested perhaps to prevent some of the complications like reflux, etc. One of the big, though simple questions we have about feeding is whether or not we should use gastric tubes to deliver continuous feeds, so drip feeds into infants, or whether we should give intermittent boluses. When we give intermittent boluses, typically over 10 to 20 minutes every 2 to 3 hours, we try to mimic something more like a regular feeding, which is episodic, as opposed to continuously feeding through an infusion pump. Although theoretical benefits and risks for each method has been proposed, the effects on clinically important outcomes remain uncertain, and hence the purpose of these reviews. Push versus gravity is an interesting question regarding whether or not gavage feeds delivered through a tube should be given intermittently via a syringe by gently pushing milk into the infant's stomach, or can be poured into a syringe attached to a tube and allowed to slowly drip in by gravity. Again, a decision that we make regarding how we deliver feeds to the baby. The definitions of these interventions are obvious, but also clearly different from each other. Transpyloric versus gastric feeding are the interventions in one review, continuous versus intermittent bolus in the second review, and push versus gravity, intermittent gavage feedings in the third review. When we take a look at necrotizing enterocolitis, we see no difference whatsoever. For the transpyloric versus gastric tube feeding, there are 7 studies involving 298 infants. We can see that although the point estimate suggests a 37% reduction in the risk of necrotizing enterocolitis, that in fact, the confidence interval is broad, ranging from 0.26 to 1.53 and very imprecise. Similarly, with the studies of continuous nasogastric milk feeding, versus intermittent bolus milk feeding, we have only 4 studies of 372 infants, and that does not suggest any significant difference in a very imprecise estimate. The push versus gravity for intermittent bolus gavage tube feeding was a crossover trial, and no longer-term outcomes are reported. In general, there are few differences reported in other gastrointestinal side effects, except in the transpyloric versus gastric tube feeding, in which there are 7 studies involving 297 infants. In these studies, there is an increase in gastrointestinal disturbance associated with the transpyloric route of feeding, the point estimate being 1.48, with a confidence interval that suggests a small increase in the risk of 1.05 or a doubling of the risk to 2.09. When we look at the absolute risk difference, we see there's a 9% risk difference in gastrointestinal disturbance, suggesting that for every 11 babies we treat with transpyloric feeding, there'll be 1 more infant who shows us some GI disturbance, including diarrhea, vomiting, etc. There is an interesting and concerning report of increased mortality associated with transpyloric compared to gastric tube feeding. 6 studies that look at 245 infants suggest an over 2-fold increase in the risk of mortality. This confidence interval ranges from 1.36 to 4.46. The risk difference of 16% suggests that for approximately every 6 infants we choose to treat with transpyloric feedings versus gastric feedings, we may see 1 more death. That would certainly give any of us great pause about thinking about this approach to treatment. However, the authors, I think, insightfully note that in these studies, the increased mortality associated with transpyloric feeding may be due to selective allocation of the less mature and sicker infants to transpyloric feeding in a trial that contributes the most weight to the meta-analysis. When we look at the effect on growth, we don't see any difference in the growth of these infants based on the routes of feeding. For the transpyloric feeding review, only 4 of the studies with 93 infants report on weight gain as grams per week. And although the point estimate suggests a 5 to 6 day lower gram per week weight gain, we can see that the confidence interval suggests a broad range that may be significantly lower or higher. The continuous nasogastric milk feeding reports growth in several different ways, but in using a standardized mean difference, we again see no difference reported in growth. And the push versus gravity studies do not report on this outcome. Lastly, let's touch base on this issue of enteral feeding strategies. There are 3 reviews that report on various strategies to either maintain or support enteral feeding. One review looks at high versus standard volume enteral feeds to promote growth in preterm infants. The review of Watson and colleagues looks at responsive versus scheduled feedings for preterm infants, including 9 trials involving 593 infants. And the meta-analysis and systematic review from Ibrahim looks at short versus long feeding intervals for bolus feeds in very preterm infants, only 4 trials involving 417 infants. The rationale for each of these approaches is somewhat different. For the high versus standard volume feeds, let's start with the assumption that human milk is the best enteral nutrition for preterm infants, and we've discussed that in previous seminars. However, human milk, given at the standard recommended volumes, is not adequate to meet the protein, energy, and other nutrient requirements of preterm or low birth weight infants. One strategy that may be used to address the potential nutrient deficits is to give higher volumes of enteral feeds. High volume feeds may improve nutrient accretion and growth, and in turn may improve neurodevelopmental outcomes. However, there is concern that high volume feeds may cause feeding intolerance, necrotizing enterocolitis, and complications related to fluid overload, such as patent ductus arteriosus and chronic lung disease. Another strategy for feeds takes a look at responsive versus scheduled feeding. Feeding preterm infants in response to their hunger or satiation clues, somehow defined as responsive, cue-based, or infant-led feeding, rather than scheduled intervals, might enhance infants' and parents' experience and satisfaction, might help to establish independent oral feeding, may increase nutrient intake and growth rates, and ultimately allow for earlier hospital discharge. Shorter versus longer feeding intervals is another approach to ongoing enteral feeds. There is no certainty about the ideal feeding interval for preterm infants. Shorter feeding intervals, for example, feeding intervals of around 2 hours, have the theoretical advantage of allowing smaller volumes of milk. This may have the potential to reduce the incidence and severity of gastrointestinal reflux and may improve feed tolerance. Longer feeding intervals have the theoretical advantage of allowing more gastric emptying between feeds. This potentially provides a period of rest for the immature digestive tract. So what exactly do we mean by these interventions? My guess is that we all have in mind our own set of thresholds for what we consider to be high volumes of feeds or standard volumes of feeds. But it's important to recognize what the cut points that were used by the authors and the investigators of the trial. They set two different sets of cut points, one for infants who were fed fortified human milk and one for infants who were fed unfortified human milk. For the studies that used fortified human milk, the high volume feeds were defined as greater than 180 ml per kilo per day, and the standard volume feeds as less than or equal to 180 ml per kilo per day. For the studies that utilized unfortified human milk, the high cut point was set as greater than 200 ml per kilo per day, and the standard volume feeds set as less than or equal to 200 ml per kilo per day. These, to my mind, represent fairly high cut points for high volume feeds. For responsive versus scheduled feeding, the responsive feeds were based on infant cues, whereas the schedules were set for feeding prescribed volumes. For the short versus long feeding intervals, short was defined as a 1 or 2 hour interval versus long, which included intervals of 3 to 4 hours between feeding. Growth was reported in 2 of the reviews. In the higher versus standard volume enteral feeds, there was an improvement in growth in the higher volume groups, both in the studies of infants with fortified human milk and unfortified human milk. In the 2 studies that looked at higher versus standard volume feeds in infants with fortified human milk, there was a 2.6 gram per kilo per day higher weight gain in the infants receiving higher volumes. This could be as little as a 1.4 gram per kilo per day increase in weight gain, or as much as a 3.8 gram per kilo per day increase in weight gain. The one study of infants receiving unfortified human milk demonstrated a higher weight gain of 6.2 grams per kilo per day, which could be as little as a 2.7 gram per kilo per day, or as high as a 9.7 gram per kilo per day improvement in weight gain. Interestingly, in the 4 studies that looked at responsive versus scheduled feeding, there was a lower weight gain in infants who received the responsive feeds. The mean weight change during the study period in the intervention group was 1.4 grams per kilo per day lower. It might be a trivial difference of 0.3 grams per kilo per day lower, or as much as a 2.4 gram per kilo per day lower weight gain. The studies of short versus long feeding intervals did not report weight gain in these infants. Interestingly, hospital stay was influenced by these feeding approaches. In the two studies that looked at higher volume feeds, the mean duration in hospital stay in the intervention group was slightly longer, 1 day longer, with a confidence interval that was not statistically significant. It might be 3.5 days shorter or 5.5 days longer. No differences were seen in responsive versus scheduled feedings regarding hospital stay, or in the group that looked at short versus long feeding intervals. Necrotizing enterocolitis was reported in the studies of high versus standard volume feeds of infants with fortified human milk, and no differences were seen with a very wide confidence interval. Studies of the short versus longer feeding intervals also did not show any differences in necrotizing enterocolitis. So that's quite a whirlwind through a series of studies. And we're going to invite in our guest discussants, Bill McGuire, Brenda Poindexter, and Suresh Gotham, to help us answer the questions and to take your questions. Where does this evidence take us? What are the best practices regarding optimizing feeding strategies and methods in preterm infants? And what future research is needed? So I look forward to our discussion with these experts and your questions that you chat in. Thank you. So, thank you all for hanging in with us. That was an eclectic whirlwind of information that I hope we can explore in the next half hour or so. We have extended this session till as long as 1:30, depending on where the interest and questions take us. I know we're all zoomed out when it comes to these meetings, so I understand if people will drop off. But I would love to both, one, go through a polling exercise with you, and let our experts, let Brenda, Bill, and Gotham all contribute, and then end with tackling some of the fantastic questions that have been chatted in. So let me start. First of all, welcoming Bill, Brenda, and Gotham. Thanks so much for joining us. These folks are truly expert in the field. And again, just mentioning any issues around sponsorship from Vaughan, as well as the Gerber Foundation. My disclosures remain the same. Vice President of Vaughan and coordinating editor of Cochrane Neonatal, with no other relevant issues to discuss. So let's just take a minute to talk about how to participate in today's webinar. You guys have been great about typing in questions. There's quite a list, and I hope that the other moderators have been looking at it and can bring some of their focus to it. As well as more formally, we're going to use Poll Everywhere to answer questions posed during the session. Let's just take a quick second to get your guys typing and polling capacities there. The question, thank you. I'm so happy when I start to see people polling in. We have well over 300 participants, and we'd really like to get some idea of where people stand. So, this is great practice, and it looks like we have had almost 2/3 of you on previous seminars, but I'm really happy to see that a third of you are joining us for the first time. So let's take a look at the practices that you guys perform and examine whether or not it's informed by the evidence, and examine some of the variations behind those practices. And I'll use the same domains that we discussed before, namely talking about how we introduce enteral feeds, how we promote enteral feeds, the methods we use, and the enteral feeding strategies. So let me first ask you guys about your understanding of what early enteral feeds may lead to in terms of improvement. What outcomes are affected by enteral feeds? And, I watch this ebb and flow, but I see a few things here. Almost half of you believe that it's very impactful, that it decreases NEC, decreases infection, and decreases mortality. But the fact of the matter is that it's more limited than we think in terms of the evidence. Just taking a look here, it's really only, in terms of a proven outcome, the risk of infection that is lowered. And this is highly speculative. Someone chatted in before, well, if it doesn't decrease NEC, what's the infection decrease that we're seeing? And frankly, this is speculation, but I think that it's based on not having as much invasive care, staying on parenteral nutrition longer, winding up with central IVs longer. And these infections, of course, we all know may be less severe. Okay, a lot of staph infections associated with that, and does not translate into a difference of mortality. Let me also ask about whether or not you have policies regarding early feeding. And I guess I should ask, do you have policies about when you start feeds? I guess is the way I'd interpret this question. The vast majority of you do. I don't know whether or not that reflects choice of earlier feeding or not. But when we look at the variation in practice, we see that there's a broad variation. And I've quoted this study earlier, and it's somewhat old, it's 2012, but it's still impressive that we see huge variation, particularly in the smallest babies who are less than 25 weeks gestation. And so I'd like to open it up to our guest discussants to make some comments around the pros and cons of early enteral feeds, what they recommend in their practice, et cetera.
Roger, I guess I can start. And I just want to say thanks to everybody who's joined this. It's so encouraging to see just how many people are so interested in this topic. I guess I would say, I think more important maybe than the what of when you initiate, but that I'm encouraged to see that so many people have a feeding protocol, because I think that's where we probably have the strongest evidence, is that simply having a protocol will improve outcomes. One of the things that I'm becoming increasingly aware of, and I think interested in, is that our data that's been presented really is for the very low birth weight infant. And, yet our guidelines, sometimes I'll see people applying the same standardized feeding approach to a 34-weeker or, to a bigger baby. And I think that probably warrants, some discussion too. But I think making sure that everybody in the unit is on board with a standardized approach is at least my interpretation of this evidence, that arriving at a group consensus and knowing that everybody will uniformly follow that, I think is one of the most pivotal things that you can do to improve practice in your unit.
So one of the comments was, and we talked about this in previous seminars, do you think that the strategy of earlier initiation of feeds depends in part on the availability of the right substrate? Do you have to have expressed breast milk, donor breast milk? Would you consider these policies with formula?
Do you want me to say that question, Roger?
Yeah, please, Bill.
Yeah. So I think the answer is yes, and I think that probably reflects practice. So not just substrate dependent or influenced by availability of breast milk, human milk, but also gestation and other risk factors dependent. And I guess this is the point that Brenda was making just now. If you have a 31-week gestation infant who's relatively stable, you may be not too fussed if mum chooses to allow formula feeding. You're probably happy with that. But a 24-week gestation infant, you'd really be keen if you're hoping to start early trophic foods or early feeding to use human milk if possible, and I guess would all be reluctant to use formula in that sort of situation at a very early stage. So yes, and again, following Brenda's point about guidelines and protocols, it's useful to have that structure. It's useful to have targets that we aim for, but the points I've just raised also indicate that we need a bit of flexibility and a bit of a bit of individual baby decision making within that, because babies in inotropes or babies with large ducts, etc., may be at different risk of necrotizing enterocolitis, particularly. So,
you know, it brings up the question that if you hope to have policies that introduce feeds earlier, at least to gain the decrease in infection risk and possibly other benefits, it really comes down to supporting collection and supporting interest in maternal breastfeeding. You know, so I agree, Brenda, about having a policy, but it's really dependent on so many other things that you have to address to at least believe we're going to recoup some of those successes. Now, let me move on and keep finding out about your practices and thoughts. And let's discuss some of the issues around promoting feeds. And I'm notorious for framing questions that have double negatives and are confusing. Ask anyone who's ever made rounds with me. But of the following interventions, which intervention does not lead to decreasing length of hospital stay? We'll give it a second just to process. And it's bouncing around, but it's relatively stable now. And in fact, 60% identified that avoidance of bottles during establishment of breastfeeds does not decrease length of stay. And mostly for non-nutritive sucking and oral stimulation, it either has been shown to decrease length of stay or has a trend towards it. So here are the results that we see. Avoidance of bottles, on average, has a 2-day higher length of stay. It's not statistically significant. It could be 3 or 4 days lower. It could be 8 days higher. Mean length of stay for non-nutritive sucking is decreased by around 7 days. And it could be 7 days lower or 6 days lower. So that's a pretty refined estimate that you get some bang for your buck with non-nutritive sucking. Oral stimulation also was reported to decrease length of hospital stay, depending on whether or not it's with standard care or other non-oral interventions. 4 to 6 days decrease was reported. But let's look at the other side of the coin. Which intervention leads to a potential increase in successful breastfeeding? I don't see much action on this. Okay, a little bit there. And the one that is shown to significantly increase successful breastfeeding is avoidance of bottles. I showed this slide earlier in the more didactic session. Not only does it, in this case, it's not a risk, it's the success of full breastfeeding. So it's not a negative outcome. So the relative risk is going to be over 1. But you can see that full breastfeeding or any breastfeeding at discharge is significantly increased. And this seems impactful. It seems to matter half a year out. And so it's interesting to see that may, in fact, be very impactful. But there's a push and pull around that, around length of stay and around avoidance of bottles. And so I'm curious, who has guidelines regarding this? So I'm not surprised that the majority of centers don't have guidelines regarding this. And I'd like to turn to my experts, and particularly I know that my colleague Gotham, Suresh, has given this a lot of thought, particularly with a view of a worldwide practice. Suresh, you want to share anything with us?
Yes, I was making the point earlier that the use of bottles definitely has a kind of contextual influence, and there are many countries in the world where bottles in the neonatal unit are actively discouraged by clinicians. So if some of the clinicians participating in the survey are from countries where bottles are discouraged and seen as kind of the enemy, we should interpret the responses appropriately. I'm seeing a response that in Nigeria, the use of bottles is actually discouraged. So yeah, that was my main point in interpreting the results of this poll.
But I'm always keen on finding out where there's extreme variation in practice and always learn from just the point that you're making. We do not actively support avoidance of bottles. It's the sort of thing, to my memory in the unit, and I've retired from clinical care for over a year now, things may have changed, but it's almost only the families that come in and request that get that treatment, as opposed to slapping bottles out of people's hands. Brenda, Bill, you have any thoughts?
I mean, I think it's one of those things where in some respects our opinions matter less than the nurses, because they're the ones at the bedside present for every single feeding with the family. And I see some of the chat talking about need for parental leave and having families being able to visit and stay with their babies, and I certainly think that's true, but we do sort of send conflicting messages, because I think if you really talk to the moms and the nurses, they're kind of getting that subliminal message that if we introduce some bottles, we'll get you out of here sooner. And so that's not a bad thing, but then how much are we undermining the longevity of breastfeeding, I think is really important, and something that we probably need a multidisciplinary approach to if we're going to make a dent in it.
Yes, and Roger, this is Gautam. I know this is a webinar on evidence, but I think this discussion is bringing out the very strong influence of beliefs and cultural practices in neonatal nutrition. And that varies a lot from hospital to hospital, NICU to NICU, and country to country.
Yeah, so most of the studies that looked at avoidance of bottles looked at cup feeding. How much of the staff has training or experience in cup feeding, such that there's a comfort level about really looking at avoidance of bottles? We think of avoidance of bottles as putting babies to breast, but there's not that much opportunity. There has to be some skill set in between to allow for that. And I'm not so sure, at least here in the US, how much of the staff is trained and comfortable with that.
In the UK, Roger, cup feeding is common, especially early on in transitioning to try and get some oral feeding. Some cup feeding and sometimes syringe feeding would be much more common nowadays than bottle feeding. Bottle feeding comes in later with some of these babies, and as Brenda suggested, trying to get the babies home, and it's usually, in my experience, used for mums who are maybe who have maybe encouraged to provide breast milk for the early phase of nutrition of their preterm infant, but whose intention is to switch to formula feeding. And we encourage mums to continue bottle feeding with their own expressed breast milk for as long as possible. Maybe they've saved quite a lot of it. So we tend to use it in those circumstances, but UK cup feeding has become very common.
Brenda, what about your unit? I mean, am I too narrow in my belief that this is not a widely utilized approach here in the States?
I've certainly not seen it used in the NICU. I think a few of our delivery hospitals in the term nursery, where they're really trying, more with some of the baby friendly, things. I've seen it used more in the term setting, but I've personally not seen it done in the NICU.
Well, again, it's a point of interest, and I think that Gautam, your point regarding the fact that this is a cultural issue, but I love the fact that that's where all of our good ideas come from. And I love looking across these various settings to see what we can learn. So
yes, I'm seeing I'm seeing a lot of chatted in comments from countries where bottles are discouraged, that cup feeding and alternative methods are commonly used. And Roger, there's a good question. When you say avoidance of bottle feeding, how long does the avoidance last? 7 days, 14 days, forever?
I don't have an answer off the tip of my tongue on that. Bill, are you familiar with that from the review? I can.
Yeah, really, you're talking about until the babies are almost ready to go home. It's not just a set early, 1 or 2 weeks. It's avoiding that until the babies are establishing breastfeeding, until they're at that 34, 35 weeks and looking to go home. That's the aim. I think the UNICEF, the baby friendly initiatives influence practice in some countries, particularly in this regard, perhaps in the UK as well.
Well, great. We can discuss it more as we progress, but let's go through the polls before we open up the discussion, because there's a lot of chat going on. Let's talk a little bit about methods of feedings and find out where policies and guidelines stand there. Specifically, it's looking at continuous nasogastric milk feedings versus intermittent feedings. Milk feedings can be given via nasogastric tube either intermittently, typically over 10 or 20 minutes every 2 or 3 hours, or continuously using an infusion pump. And each has potential benefits, though the outcomes remain uncertain. So, question about, specifically in the population of infants less than 27 weeks, do you have policies regarding the use of bolus or continuous feeds? And so, I ask this question almost every time, not this question about feeds, but the issue of, do you have policies, to reinforce Brenda's point that, in fact, having a policy and having a standard is probably extremely important. Of course, it's important how well you do whatever you think is the most evidence-based procedure. It's also important not to drive the nursing staff and parents crazy about saying, oh, Roger's on service, so we do it this way. But you can see that almost 60% have policies, but I would encourage the other 40% to consider it. Again, when we look at this most recent, the most recent poll I can get my hands on from 2012, we can see that there is great variation about how people proceed. And that's including both the smallest babies, less than 25 weeks gestation, and the larger babies, not larger, but 25 to 27 weeks gestation, where tube feeding is going to be critical, ranging from as low as 3% in Canada for continuous feeds to 20% in Scandinavia. Any comments from the panel?
I would say, for some of these things too, I see a difference in what's your default method and, what, when you're starting, are you doing? And then, so for example, helping to educate the nurses on, if we're starting out with continuous, we're losing a lot of that fat content in breast milk that's adhering to the tubing. And they're like, oh, okay, we didn't know that. Let's start with bolus and then reserve a switch to continuous for, if it's the choice between to go to continuous or, have to halt or interrupt feedings. And so, I think thinking about it not so much as a what do you always do, but sort of what's your trigger to, consider an alternate approach if the baby's not cooperating with your default approach.
Yeah, there clearly is an art to this,
Mm-hmm.
and having a routine approach. But you can see that some babies are not doing well on your stated approach, and it's appropriate to think of changing. All right, so let's move on to some of the final poll questions before we get to just an open discussion. And this is really about enteral feeding strategy. And I'm just focused here on the high versus standard volume ventral feeds, which we discussed earlier more formally, with different strategies based on whether it's fortified or unfortified. But a cut point for the infants who are fortified of around 180 milliliters per kilo per day and unfortified around 200 milliliters per kilo per day. And let's take a look at your own practices. Do you have policies or guidelines related to target volumes of feeds? Interestingly, how many have chosen this as something to standardize? And perhaps it's seen as somewhat easier to state than other guidelines, which tend to be complex if you're looking at who's really physiologically stable to do all these other things too. This may be a more straightforward one. Again, looking at the results, leaning towards higher than standard volumes will decrease your length of stay and improve your growth. There is, however, great variation in practice when we look internationally. So I'd love to hear from the panel about approaches to the target volumes of feeds.
Yeah, I think this tends to be one of these contentious ones on rounds in the morning, Roger. You know, I'm pushing 200, 220 mils per kilo per day, and the nurse who's looking after the baby all day, every day, is saying, you know, don't do that. You know, but to me, it's a reasonably, it's simple maths. The expressed breast milk's got 67 kilocalories per 100 ml. We'll give 200 mils per kilo per day. We're given 130, 135 kilocalories per kilo per day, which is what we recommend if we want to look at something close to intrauterine accretion. So it just makes sense. I'd rather go to 200 than 45. You know, I'd rather see a baby grow on 200 mils per kilo per day than 45, 150. But there's huge variation in practice. A lot of the evidence and the emerging evidence for using a higher volume strategy, of course, like so many enteral feeding evidence for enteral feeding strategies coming from low and middle income countries, where provision of care for babies of 27, 28, 29 weeks gestations expanding. There's demand there, but resources are fewer than 45, for example, is not so available than in wealthier countries. So we're accumulating an evidence base from studies in India and South America and other countries where sort of needs must. Give more, baby's not growing, give more milk, don't add a bovine fortifier. So it's one I have a sort of personal, there isn't a day on rounds where I don't have a bit of a discussion about this.
Well, that's the tension, isn't it? This whole issue of fortification versus volume, and where the efficacy lies and where the risks lie. And I take your point that I think that we think too little about pushing volume is what I take from these reviews. I don't know, Brenda or Gotham, any thoughts?
Yeah, I think that, I mean, it's certainly in areas where fortifier is not available, I wouldn't quibble at all about pushing volume. But I think, you know, especially if we're using more donor milk as the base, I don't think that simply pushing the volume is going to capture all of your micronutrient and vitamin and mineral kinds of needs. And so I worry that we might feel falsely reassured by weight gain and really not be looking at bone health in some of our tiniest babies. You know, I think there is growing concern in the community about use of fortifiers, and I don't think that, you know, really any of it is that well founded. And so I think we have to be careful to kind of go back to why fortifiers were developed and how essential they are for our tiniest babies. And, you know, frankly, in some cases, you need both. You need additional fortifier and you need additional volume to meet growth expectations.
So just to differentiate though, Brenda, because I'm old enough to remember when we were busy just adding the minerals and vitamins to each feed, and fortification was just a matter of calories. Should we think more about separating the two again? We tend to get lazy of wanting just, you know, pull in a capful of fortifier that includes everything. Is it worth rethinking that approach?
I guess possibly, but you know, I mean, you know, where are you going to do that? You know, I think there's risks in having the nurses adding multiple things at the bedside. If you are lucky enough to have a milk lab where, you know, they can do targeted or individualized fortification, maybe, but I tend to say keep it simple and keep it safe, and the fewer things that we're adding, at least in my opinion, is a better process measure to ensure safety.
Gotham,
Yeah, Roger, if I can just add a brief comment, a lot of interesting comments being chatted in. I think this slide and issue of target enteral volume brings up the tension between a guideline that has a one-size-fits-all approach versus precision nutrition. And I believe we should try to balance the two. If a child doesn't have reasons to restrict fluids like BPD or PDA, then we should try to use the highest volume possible and monitor growth, bone health, and ideally lean body mass, not just a body weight. And having a dietitian as part of your daily rounding is very helpful in calculating the actual intakes and the requirements. And are we meeting them? And is the baby achieving the goals of nutrition, of which growth is just one aspect? So I think this requires a balance between one-size-fits-all guideline versus precision nutrition, where you monitor, and having good calculators and software to calculate what the baby is getting and the results, and having a dietitian is very useful to decide this.
I'll just add to Roger. I see that Tanis Fenton is part of our group watching this, and she made a point earlier that you know I would really want to emphasize, and that's this, you know, when we're looking at postnatal growth, making sure that we're taking into account that early weight loss, and that we're not expecting the babies to grow along necessarily their birth centile, but really taking into account that initial weight loss, and then, you know, looking at about a week to 10 days, and making sure that at that point they're tracking along their centiles, not just for weight, but also for length.
So I've imposed on Tanis to ask her to make some of these comments.
Awesome.
And I've asked Andy to unmute her. Very powerful thing to do. No one should unmute Tanis Fenton.
Yes, much better.
Tanis, can you get online and join us? And I'd like to expand this whole thing.
Wonderful.
There's been a lot of chat about the right measures and whether any of these studies utilize the right measures. So Tanis, we would love to hear from you.
Oh, great. Can you hear me, Roger?
Hear you loud and clear.
Great, great. I think there's a lot that could be said. And a lot of these studies, most neonatal studies, look at whether weight gain was greater or not. And without standardizing it, you know, where were the baby's growth patterns to start with? You know, was the control group actually growing beautifully, and then is it excess gain? Not likely, but you know, without standardizing it, it's hard to interpret these studies. And thank you, Brenda, for pointing out the problem with using the 10th or the 3rd percentile at discharge, because if we expect babies to weigh more than the 10th percentile, all of them, then that means a lot of babies are gaining weight to overcome that postnatal weight loss, and they're actually growing faster than the intrauterine growth rates.
So what would we like to see studies measuring when we're looking for what is efficacious, what is success?
It's kind of a complicated answer. One suggestion that did come up in the chat box, which I think is probably the best one, is to look at changes in Z-scores from ideally the nadir or day 7 and following along, because that's looking at growth. Excuse me, if we include that first week of life when they're losing weight and finding their way and hopefully getting some enteral feeding established, they're not growing in that first week. So we shouldn't penalize them for that. You know, if we look at a change of Z-score from birth to a later point in time, it includes that postnatal weight loss, and it's going to be less than the intrauterine weight. So I think we should start after the weight loss. And the change of Z-score has been recommended by a position paper by Dina Goldberg and colleagues, published in 2018. That came up in the chat box too. I think that's the best way to go right now, although that hasn't been validated. Actually, the VON data would be a good body of data to validate that, similar to your and Dr. Harbour's study from a few years ago. To repeat it, looking at changes of Z-scores from day 7, I think would be really interesting.
And there's some excellent online calculators. Most EMRs with the growth curves, you can look at the Z-score. And so I think an easy thing for everybody on this call to do is, like, as you're rounding each week, instead of asking what was the average weight gain in grams per kilo per day for the last 7 days, you know, getting people more familiar with reporting, especially those weight and length Z-scores, I think is a really simple and effective way to kind of reinforce that we care more than just about that absolute gain in grams.
Yeah, good points, Brenda. I encourage people clinically to be looking at the growth patterns, because as another point came up in the chat box, we wouldn't expect an SGA baby to have a Z-score above, above the 10th percentile, which is minus 1.28 Z-scores. And we need to look at the pattern. On the other hand, actually, there's a few papers that show that in terms of growth velocity, SGA babies actually grow at a faster velocity. And that's probably because they're showing some catch up for those that are actually growth restricted. And the SGA category actually includes some small babies who aren't growth restricted, as well as growth restricted babies, just because it's an arbitrary category.
Gotham, I noted in your chat, you suggested some other outcome measures that might be included when we think about both future research and our clinical practice.
Yes, I think Tanis's work and the Intergrowth project have shown us a new way to look at conventional growth measures such as weight and length and head circumference, but we also need to have other outcome measures for growth that measure body composition, including bone health. And we really need to be measuring the lean body mass for true improvement in the baby's growth and nutrition, not just the overall weight, which can include a lot of the fat that is accumulated, which is disproportionately high in our preemies, as we know.
Yeah, I'd like to make a point or two about that. Thanks for those points. There's a review that was published a couple of years ago, well, 2020, I guess that's coming up to 2 years ago, that looked at the body fat composition at different time points and summarized the available studies. And the body fat content is higher at term in babies who are born preterm compared to babies who are born at term. But if you look at 3 to 5 months later, their body fat composition is almost identical. So I think what we're seeing is a postnatal adaptation that infants put on some body fat. So I think we shouldn't restrict growth on the basis of higher body fat. And as you're saying, Dr. Ganthan, we need to look at the lean body mass. I don't know that we can totally correct that before discharge, no matter what we do. I think, the stress of being in a NICU and everything that happens to the babies, plus they, aren't coming, they may have had some prenatal morbidities as well that they're not identical to the term population. So I think what we need to do clinically is look at each individual and make sure they're growing as we would expect. And then we do need metrics for summarizing for research, for sure, like changes in Z-scores.
Oh, fantastic. I'm going to open things up. There's such active chat, guys. I'm never going to get to a great deal of it, but I'm so happy to see it. There's been a lovely global perspective. Obviously, we've got an audience that spans the globe, and I'm really appreciative of that. Towards that end, though, two of my colleagues in global health, Susan Niermeyer and Danielle Errett, have both reminded me to make sure that I at least reinforce some of the non-GI influences on successive breastfeeding, and not to fail to mention kangaroo mother care and other aspects of care that have clearly been shown to help with these outcomes. Because I have not been able to keep up with the chat, let me just ask the panelists, the other moderators, what questions would you like that you picked up from the chat that you'd like to try to address that you saw here? It's a lengthy list now.
I think, Roger, one of the things from scanning the chat as it's come in is it really illustrates that our approach, or the approach we've had in Cochrane, is to take separate questions, break them down, and try and answer each individual question, and that's fine from our point of view. But early nutrition is such a complex cascade of interventions. One leads to another, they're all interrelated. And I certainly got that from the chat, that some of the things we do are entirely the part of a complex network of interventions. But following your point there are themes that run through these, themes such as promoting use of breast milk, strategies to promote use of breast milk, so that will come into things like responsive feeding or higher volume feeds, etc. These are all linked together. And then the other theme that I think comes out, and maybe just following from the conversation we had with Tanis and Brenda a few minutes ago, is that we tend to think of nutrition or early nutrition as being about promotion growth or bone health, etc. Whereas, when I was a young doctor, nutrition was about development. Nutrition was about the brain. We didn't tend to fuss too much. We didn't tend to worry too much about how heavy a baby would be at 36 weeks when we were going home, or whether they were on the 3rd centile or the 10th centile. It was about optimizing brain growth. And outcomes from nutrition studies should still, I think, include evaluations of neurodevelopment, particularly because the determinants of neurodevelopment and avoiding cerebral palsy aren't just the amount of calories, the amount of protein, or amount of other nutrients we supply. The big predictors of poor outcomes are infection and necrotizing enterocolitis and other adverse events that, as you've illustrated, are related to our nutritional strategies. So it is very complex, and sometimes we look too hard at how many calories are in breast milk versus formula, or how much protein. Whereas as avoiding these big catastrophic events that have very, very severe adverse consequences for development and growth, actually, that are important. So those sorts of themes, I think, emerged through the chat. It was quite illuminating just to follow the chat. So thanks for everyone who's contributed.
There's been a few questions about resources regarding Z-scores and learning about how to use Z-scores. And I'm not sure there have been some links that I'm checking on now. But I don't know, does anyone have any thoughts about what we can provide the audience regarding learning more about Z-scores? we could put our heads together and distribute that post-conference, but I think that many people have clearly heard that they need to familiarize themselves regarding more up-to-date metrics. Towards that end, where does this evidence take us ultimately? What are the highlighted points that you might say? And perhaps importantly, since we're hearing about the lack of measures, where would you like trials to move? What direction would you like to see trials go in?
So Roger, if I can pipe in, I think the chat has revealed one glaring obvious fact, and that is the provision of neonatal nutrition in underdeveloped and lower and middle income countries is very different from that of developed countries. So I think we need focused research in LMICs that will answer the questions relevant to that context.
And I think, Roger, we've learned so much from some of the innovations in low and middle income countries. Kangaroo care is the obvious one. You know, we've adapted that in wealthy countries we've rebranded it as skin to skin care, but we're having some of the advantages that are associated with the entity of kangaroo care. But for instance, in the UK, we're undertaking a big trial just now of early full enteral nutrition. So we're randomizing babies at 30 to 33 weeks either to full enteral nutrition with no parenteral fluids or to a more standardized approach. And the reason we're doing that is because there's been evidence from a number of trials in India demonstrating that this is an effective strategy for reducing the number of invasive procedures and potentially for reducing things like infection. So we're learning an awful lot from countries with fewer resources and try to adapt some of the lessons that have been learned there.
That's a truly important point, and how eclectic these needs will be to look at what's really available, what's doable, and what are the issues, and what is the post-discharge care going to be? Gotham?
Right. What is the feasibility of coming up with a core outcome set for nutrition, like has been attempted in other fields? Is it possible for all of us to agree that these are the core nutrition-related outcomes that we will study in future trials?
You know, that's a great point, because it's easy to lean on the low-lying fruit and what's accessible. But what we're hearing from many people like Tanis Fenton and other experts, is that these are not the measures, and hearing from Bill that we have to commit to longer-term developmental outcomes to make it meaningful. You know, all that core outcome work has just barely been scratched, but it is critical to set a standard. So that's a great take-home point. We only have a couple of minutes left. Brenda, any other take-home points for us?
I think this is, thinking about what are the quality metrics that we want our units to be measured by. And really, I think we need to be leading that rather than letting outside bodies like US News and World Report or other things decide for us what they think is important. And including in there, I think, the perspectives of the families. And so, as we think about post-discharge nutrition and, really what is that mom's goal? Does she want to do direct breastfeeding exclusively? Is there a balance between, introducing some attempts at the breast with some, more highly concentrated fortified feedings to preserve growth? How do we do that handoff with the pediatrician or with our follow-up clinic to make sure that some of these things we've achieved in the NICU are continued post-discharge? I think those are all phenomenal areas for, people on this webinar to potentially pursue as a research or quality improvement project. Great.
And I guess special thanks to Tanis for jumping in and joining us. Tanis, any concluding remarks from you? That was so kind of you to come on board.
Oh, I'm very pleased to join, and I think the comments and discussion have been excellent, and I agree that we need to look at outcomes beyond growth including development, and we can use development as an outcome to evaluate different growth outcomes to see which ones are the better measures.
Well, fantastic. So we've come to the end of our hour and a half, and we've sustained the listening audience pretty darn well. So thank you so much. It is fantastic to see this, the chat, the thoughts. What I see in the chat is we all have some thinking in our own units to do about standardization. We have learning to do about how we're going to measure and follow growth. From a trialist, I think this issue of core outcomes is key. We can't just keep saying we should do better without defining what better is. And I, of course, very much want to thank my colleagues, moderators, and panelists, Brenda Poindexter, Bill McGuire, and Suresh Gotham. We will be talking next month, actually. We'll be replaying some work that Vaughn did on transfusion practice. And we will make sure to invite the Cochrane community to join us on that. And hopefully this summer sometime address all the updates on the reviews of cooling. So hope we'll see you then. And I thank you all so much for sticking with us in this Zoom atmosphere for an hour and a half, and such active participation, many critical thoughts, and a lot of suggestions for us to take home and think about. So thank you so much.
Bye.